A very good morning to you. This is to be a hugely relevant and insightful day of talks. The team here at National Health Executive have been working flat out behind the scenes to prepare an event packed full of industry leaders and innovators ready to share their experiences and learnings with you. Perhaps you've been to one of our NHE 365 virtual events already, or you're new to the platform. Either way, you'll hopefully be interested to hear we're building more than just a series of singular, disconnected events. We're building a platform and a community, an opportunity to connect and learn from one another long after today's talks are over. When we first set out on this virtual events endeavour, we weren't the first out of the gate, but that was intentional. We took the time to listen to what mattered most for you, and we hope that we've built a platform which really reflects that. There are opportunities to listen and absorb a wealth of information throughout today, but also chances to network with your fellow delegates. Access valuable resources from our event partners, which you can share with your teams post-event, and all of the content from today is CPD certified. For every hour of content you watch today, you'll earn 1 CPD point. The team at NHE 365 will issue your individual CPD certificates following the event. When it comes to topical themes too, there's perhaps not many more relevant things for us to be discussing in the healthcare space right now than infection prevention and control. IPC has been hugely important for as long as organised medical care has existed, but it has maybe never been as firmly in the public eye as over the last 18 months. PPE has dominated conversations. New phrases and words have entered our everyday language and become the norm. We've turned parts of our hospitals into infection hot and cold zones, and many hospital staff who previously wouldn't have encountered the same strict infection control measures as their clinical colleagues have had to adapt and learn. All of that has needed new innovation and collaboration between NHS teams and beyond into public health and wider. Our panellists come from all these walks of life, from NHS, IPC and estate teams through to local authority public health sectors and academia. Beyond the talks, there are several other opportunities to network. During each of our breaks, there'll be a chance to take part in our platform's speed networking functionality. Jump in and meet your fellow delegates. Spark up some quick-fire conversations. You never know what you might learn from one another. You're also encouraged to explore, jump into the digital marketplace, our virtual answer to an event exhibition floor, but without the usual experiences of getting lost or breaking the step counter. Located all in one helpful place, you'll be able to engage with event partners and gain access to valuable resources you and your teams can digest at your own leisure. Without their support, events like this simply wouldn't be possible. Representatives from our exhibitors will be on hand too, able to help with any more specific questions that you may have. Dive in and learn more using the digital marketplace button on the right-hand side of the timeline. And there's another benefit to all of this too. We've got a bit of friendly competition going on, which the team has put together to reward you for your hard work today. Score points by engaging with the platform's different elements and potentially earn yourself a choice of reward come the end of play. Gamification tools will be active throughout the day with an up-to-date leaderboard tracking delegate progress. Those who finish in first, second and third place respectively will have the choice of 3 different prize options to a total of 250, 150 and 100 each for the positions. So you can choose either Amazon vouchers, a donation to a charity that means something to you, or the planting of an equivalent number of trees. Whatever resonates most with you, you can only be in with a shout by getting out there and engaging. Join a live session, there's 50 points earned. Make a connection with another delegate in the platform, 100 points. Ask a question in a session, which I hope you'll do, or engage with one of our exhibitors, another 50. You get the gist. And finally, as we get ready to hand across to our first speaker, feel free to share interesting things you hear throughout the day across social media using the hashtag NHE365. That's hashtag NHE365. Let's see if we can get today's event trending and share some of the amazing things the health industry can achieve when it comes together. So first up to our virtual stage, I'm delighted to say that we've got Dr. David Nicholl, a consultant neurologist at Sandwell and Birmingham Hospitals NHS Trust. Dr. Nicholl is a neurologist and specialist in Parkinson's disease, who, along with colleagues, recently authored a report entitled Nosocomial Spread of COVID-19, Lessons Learned from an Audit on a Stroke/Neurology Ward in a UK District General Hospital. It's my absolute pleasure to start the day off by welcoming David to our virtual stage. It's all yours, David.
For the introduction, I felt very nervous being asked to infection control conference when I'm not an infection control doctor, but in a sense that's the point. I don't think there's anything special about what we've done. I think we're just brave enough to talk about our dirty laundry, which in effect this study was about, basically. So what I'm going to be talking about is what happened in the first wave. We got hit. This wasn't particularly a COVID ward, but it soon became a COVID ward. So I'm going to talk a bit about what we did, and we realized that we decided to look at this, essentially getting all the juniors involved in a quality improvement project. And I'm going to talk a lot about what we've learned and even what we're continuing to learn. Next slide. So in terms of the definitions we were using then, and this was in this paper in Clinical Medicine. In fact, all of the information's there. At the time, we were talking about patients who had a clinical suspicion of COVID with developing symptoms more than 14 days after admission. Now, obviously, that definition has become somewhat tighter, since. Just go on to the next slide. So of the patients, we had 133 patients during the first wave. So as I said, this is a stroke and neurology ward. So we had many patients who were post-neurosurgery or with tracheostomies and things. And although the headline figure of, just under 16% of patients turned out to have a COVID, this actually wasn't significantly different to the percentage of cases coming in from the community at that time. But clearly, 8 of those were hospital acquired by that definition of 14 days, 38% of those within the sample. So this was a big number. And just by way of introduction, what we then did was we decided to write this up, and I'm going to link this in a bit because we ended up leaking the data to Newsnight because we felt this was so important that people learned. So what I'm going to do is play the video from Newsnight. I have to say this still puts a shiver up my spine when I see what happened next. If we could just play the video.
The ward had 22 beds and 3 more in individual rooms. It was a neurology ward where many patients were already seriously unwell and where many were undergoing medical procedures likely to lead to the patient coughing and potentially increased risk of COVID spreading. This animation tracks from the 12th of March to the 25th of April, 21 patients who would test positive for COVID at some point in their admission. A yellow circle means the patient has been tested for COVID-19, and red means they've tested positive. It becomes apparent that, with bed occupancy high, patients are being moved from one bed to another very frequently. Patient E had been in another ward elsewhere in the hospital. On the 29th of March, patient E, who is displaying symptoms of COVID, was moved into a side room and tested. The next day, patient E was moved back into their previous ward. The following day, they were transferred first to bed 1 on Bay 1 and then to bed 1 on Bay 4. Then on 1st of April, they're transferred to a side room, and later that day, their test comes back. It's positive. In the space of 4 days, someone suspected to have had COVID occupied 5 different hospital beds, coming into close contact with so many other patients.
I'm just checking that stop there. Okay. So if we just go on to the next slide. No, I mean, that video, it's insane. Okay. But that's a reflection of the way the NHS was in terms of bed movements and things. And I suppose that's what we've really learned as part of is that we have to prioritize infection control over bed pressures, which is a real challenge. And there were multiple things we learned. Top left, we found that patients being isolated in side rooms, but being cared for by the same staff as low-risk patients. Something like, and bearing in mind this was wave 1, so we didn't have the same testing capacity that we now. 39% of all clinical staff questioned had a positive COVID-19 PCR, but not all symptomatic staff were swabbed and things. This, as I say, was back in wave 1, but all these movements really didn't help. And also there was the potential for false negatives with PCR, and I think this is probably a greater risk with kind of neurology patients, because it's maybe sometimes harder to get a decent swab. And also there was a variable turnaround time, of anywhere between 1 and 5 days at the time. I think there's just so much we've learned since, basically. But I think this population, bearing in mind our nosocomial rates as a trust overall was around about 4% at this time, a lot lower. I think this particular patient population is more vulnerable by view of, if someone's had a major neurological problem, their ability to complain about fever, about cough or loss of smell, just isn't there, basically. So it may be longer before the diagnosis gets picked up, which is why regular swabbing is so important. When I think back then, the first patient we had, this was right at the beginning of the pandemic. It was, 6-bedded bay. One patient with a tracheostomy opposite another patient who'd come in with a stroke, who had a EMRT call, got called to ITU, and people weren't wearing proper PPE because we didn't really know what we're doing. No less than 19 members of staff went off sick as a consequence. And, frankly, we were bloody lucky. No staff members died. And if I look at the number of patients that died, that 25-bedded ward, we had 10 deaths on the ward, which was the same as the entire population of Taiwan had last year. I mean, just incredible. So in a way, some of the messages I would say is that we need to think of infection control and look at what Asia did, what countries like South Korea did, and be as obsessive about infection control as they have, rather than any one individual thing. Just moving on to the next slide. So in fact, when we reordered this, obviously this was a lower prevalence time. We only had 2 patients positive, and neither case was nosocomial. And I think it's almost inevitable, if you have high community rates of COVID, you will end up with more hospital-acquired COVID as well. Next slide, please. And we summarized this in this table, and there's lots of different things that we put in the paper, but in summary, we just need to all act like South Korea. That's basically what I would say. The only thing I would say is different that we've learned, which we didn't have really anything significant in the papers. We also need to think about ventilation. And I think that's really hard with some of the estate that the NHS got, old buildings, shared coffee rooms, limited office space, inability to open windows and things. But I think ventilation is something we're going to need to think about. Next slide. And then we thought about in the summer, and I think about this quote from Jaws: "We've got to get a bigger boat because we need to be ready for the second wave." And so what did we do? Next slide, just to show this photograph. Well, we designed, and I hate this title, the CIA, and it'd be the COVID isolation area. Never name an area of a ward by a disease. And in fact, it wasn't big enough. And when we had the second wave over the winter, we were full of COVID. Obviously, we're in a different place now with a vaccination, and that hasn't been reflected, although there's been a greater increase in younger patients with COVID, that certainly isn't being reflected in the stroke unit. Next slide. But what have other countries done? And I think it's just worthy debate. This was a study in Vietnam, okay, and they described their outbreak of COVID in one of the main hospitals in Hanoi in Vietnam, basically, and they had three COVID cases, okay, that led to contact tracing. They closed the entire hospital for quarantine, okay, so they got nearly 8,000 staff to quarantine. They contact traced 52,000 individuals. I mean, fantastic in terms of infection control. But I think the counter argument to that is how many patients were harmed by the local hospital closing down for quarantine. I think that's a difficult question, but something that does need to be thought about, because all of this is a balance, and actually just thinking about the risks of all the interventions we do is actually really important. And we'll talk about risks. I'm going to lead on to this because we wrote this paper in Clinical Medicine about the outbreak we had on the first wave. Not surprisingly, the media approached me. Now, in fact, the Newsnight story I showed, we weren't named because my trust was very, very nervous about putting the head above the parapet. And yet I think we should be talking about nosocomial rates in exactly the same way as we would for C. diff or MRSA, for example. So next slide. So in fact, when the Daily Mail approached me, you give them a quote and you get this kind of headline. I mean, just your heart sinks. It basically feels like the NHS, killed my grandma type headline, basically. I still stick by the quote I gave. Just click to the next bit of that article. I said that, we should be transparent about data. It's actually pretty sad that newspapers are having to do FOIs to try and get the results of what the hospital-acquired COVID are. We should stop acting like North Korea and act like South Korea. This stabbed me in the back a bit later. Just next slide. Because then the Guardian rang me up saying they were doing FOIs looking at hospital-acquired COVID. And I, gave them some information about our study and things like that. And honestly, I'm not making this up. My own trust was one of the ones that didn't reply to the FOI. So it appears that, we're obviously part of a conspiracy not to talk about things, even though it was just someone just didn't get around to replying to the FOI. But it shows some of the difficulty about, the public are very, very worried about COVID. I would argue that, we should be transparent about our data because I think there has been incredible variability in nosocomial rates really across the UK. And if we understand why that is, then that will hopefully we can learn from those areas with good practice. And I'm not saying we're the good guys here. So I'm just going to finish with the last slide. A big thank to my co-authors there, Yimeng and Soraya. You notice we're wearing John Snow masks, the founder of modern epidemiology. And in a sense, what we were doing was just looking at where the patients moved to try and work out where they'd gone. So happy to take any questions or any things that Helen wanted to raise about me slagging off the media.
No, I tell you what, I wish you'd leaked your exclusive to BBC, to the One Show, which I freelance for. We have 5 million viewers a night, and we would have also done it proud, like hopefully Panorama did, or Newsnight did rather. But it makes me sad as a journalist, sad and totally unsurprised to see how the Daily Mail handled it. And that's a great shame, because you said you were brave enough to talk about your dirty laundry and all these things. We need all these stories in the public eye, and it makes me, sad to see how they handled it. Looking back, do you regret that you went public with it, David, or thanks to the Newsnight piece, it was the right thing to do?
No, I absolutely think it was the right thing to do. But I think actually some of the debate we've had in terms of infection control the last year hasn't been helpful, because the story always seemed to be, masks or no masks, 2 meters or 1 meter, when actually it really is all of it. Okay. And if you look at I was very simplistic on this. Some people say, we haven't done randomized controlled trials on this. And, when you're in a crisis, in some level, okay, there is a place for RCTs when it comes to the whole dexamethasone story and things like that. But when you're doing massive behavioral change, you have to act fast. And in fact, the WHO said, the priority of speed, basically. But if you looked at, the countries in Asia that did very well, they were all wearing masks straight away. They, were very obsessive about infection control. And I think it's still an issue that there's a lot of complacency. Now, conversely, if you look at what's happening in Asia now, is they haven't had their vaccination rates up, and there have been outbreaks even in some of the countries I've mentioned. But you need both. You need vaccination to truly get proper herd immunity, but you have to follow the infection control practices. But it's still an issue. Even today, fortunately, he says, touching wood, things are better. But if I had an incident a few months ago, referral, where I didn't see the donning area, and I just said to the staff, I ain't coming to see this patient until you sort out the donning area. Thank God I'm not the health and safety executive, because I'd be giving you a hard time. And I think it's the complacency we see in the public. Sometimes we also see within NHS staff.
Do you really see it within the staff?
It's incredible.
Yes, that is quite surprising.
Because I think we forget we're a reflection of the public. When 1.2 million people work in the NHS, it's not surprising that you get those range of opinions and things as well. But I think the transparency is incredibly important, because in a sense, all the things we've been doing over the last year have been incredibly difficult for the public. So they need to understand. I mean, the hardest bit has been patients not visiting, and in an infection control side of things. Some of the conversations I've had on intensive care, end of life conversations with family, it's been absolutely horrible when you've literally had a stopwatch with the relatives. They've got 12 minutes to be in, otherwise they have to leave. And that's
heartbreaking.
Really difficult.
It's funny, you started off by saying that you're not infection control, but actually in your line of work doing such intricate neurology work, I mean, it's key, isn't it? Infection, and it's such a different, delicate part of people's bodies. In that graphic that you showed from Newsnight, the bed hopping sort of reminded me of a game of drafts or something. And I suppose it sounds quite a naive question to ask, but why is there so much bed moving? Because clearly each of those patients has a bed. So why would they not, for their own comfort, as well as COVID-19, obviously, why would they not stay in the same bed? Does it depend on what facilities are available in that particular ward and what their needs are medically?
Absolutely. Well, so that's a stroke ward. So that is also not having gender breaches and things. So it's all those different issues. And I think, and also, I think we have failed as a system in that we've regularly run the NHS on 95% plus bed occupancy, and that creates its own stresses, and we can't manage that. And we're seeing that now. People don't understand, well, A&E doesn't seem that busy. Well, that's because patients are waiting in the ambulances outside to get in, because we need to manage this from an infection control issue. We cannot go back to the way we were before, because we're still in this pandemic, and because we also know that the particularly younger, less likely to be vaccinated population are more at risk. So, that's why the infection control issues are absolutely the number one issue and how we manage them. Which is why the next speakers, I think, are so important to think about the where next and what we're doing next, basically. And also, the issues about ventilation, I think, have not really been properly addressed, and particularly with the Delta variant being more transmissible, that is a big issue as well.
Well, I just wanted to end just finally about PPE, and one of the stories that broke my heart at the beginning of this pandemic was the fact that we had amazing healthcare professionals and consultants like you, without sometimes enough gear. You actually did an aerobatic flight yesterday, didn't you, which was part of a charity raising money for your PPE. So how did you fare at the beginning of COVID? Were you all protected well enough in your hospital?
I was very lucky. In fact, Dinah, our finance officer, was fantastic at her ability to track down PPE. And yet I know of other trusts. In fact, I'm actually, I won't name the trust, but a colleague of mine who is morbidly obese, who couldn't get access to proper gowns and things like that, and he got very ill as a consequence.
Well, I hope you enjoyed your aerobatic flight that you're telling me about before the conference. And can I just say, David, it was fascinating stuff. Well done for being brave enough to go to the press and getting your stories out there. And I think you've really set the scene for today's conference. So it's been wonderful to have you as a guest, and thank you for sparing time, because I know you're working today.
Thanks very much. Have a good conference.
Indeed. Well, next up, ladies and gentlemen, we have our first leaders debate covering the future of infection prevention and control. And given all we've had to consider our IPC policies and measures over the last 18 months in all healthcare and general public settings, what are the lessons that we've learned? Should we be thinking more, as David said, South Korea, and what support is there long after the pandemic, and how can we better prepare ourselves for the future? We've seen changes in the public health approach to infection and a wider cross-section of NHS and healthcare staff using PPE and the likes. Are these the types of consideration we must continue to consider going forward? Well, to help me answer these kinds of questions and many more, I'm delighted joined by Dr. Lucia Pareja-Cebrian, consultant microbiologist and director of infection prevention and control at the Newcastle upon Tyne Hospital's NHS Foundation Trust, Alice Wiseman, director of public health at Gateshead Council, and Chine Eyetan, ICNET clinical safety officer at Baxter Healthcare. Now, do remember, this is your opportunity to ask any questions that you may have of our panelists. I really want to make today feel like a conversation with me merely being your host and your facilitator. You can pose a question really easily using our live Q&A function on the right-hand side of your screen, and I'll put as many of those questions as I can once we get the debate going to our guests. So welcome to all of you. I think my pronunciations were probably a little bit poor in the introduction, so forgive me if I didn't do a very good job. But I'm sure all of you, have had many different journeys over the 18 months, just like we were hearing from David. And I'd like to just sort of set the scene for me, if you wouldn't tell us what yours was like. And perhaps we can start off with you, Alice, and ask what your experience was like at Gateshead Council.
Yeah, I mean, obviously it's been an unprecedented year, and directors of public health have been around for a long time, but not many people knew who we were or what we did. And actually infection prevention and control is only a really tiny part of what we do under normal circumstances. So we were really sort of pushed to the forefront in terms of, picking up some of these challenges that we've got at a population level. So much more focusing on actually how do we engage with our communities? How do we ensure our communities have access to the right information to be able to do the right things? We struggled with many of the challenges that David was referring to in his earlier presentation, but at a slightly different sort of scale in terms of actually how do we get the messages out there? How do we encourage people and motivate them to do the right thing? And also, how do we provide support for all of the important, both NHS and social care? And I think we're here today to talk about the NHS, but the NHS is only part of the picture for many of our residents. And, the support that we've had to provide to our care homes, for example, was absolutely critical in those early days. And, just having that conversation around lack of PPE, that was a really big issue in the early days for our care homes. And we weren't necessarily always able to provide them with the necessary PPE to be able to protect themselves and the residents. So, a huge learning curve over the last 12 months and, focusing very much on how it's felt in our communities and how it's felt collectively as an area, but then also the differences that have been felt for different communities across the patch. So, lots of learning over the last 12 months, and lots to reflect on. And I think lots of things that we can do differently to make things better should we ever be faced with this sort of challenge in the future.
Well, we'll definitely come on to that a bit later, Alice, what we can do better, what lessons we've learned. Chine, how was your experience in your role as clinical safety officer for Baxter Healthcare?
Can you hear me?
Just check. I can hear you.
Yeah, so I think for us as suppliers of technology to the NHS, it was more about what our technology was able to do and help our customers with doing as they were going through this unprecedented scenario. Our customers were telling us, that they were able to use our system, our digital clinical surveillance software, and that enabled them not to drop any balls. So on a normal day, we know that IPC teams have a fair amount of balls to juggle, like we've heard from Alice, and although she says, it's a small part of their job as in terms of public health in general, the IPC teams in the hospital and even at public health level have a fair amount of balls to juggle. And the pandemic saw a dramatic increase in their workload, really unprecedented increase in their workload. Now, the fact that we had COVID, the emergence of COVID, did not mean that the other microorganisms that they had to keep an eye on went away. It didn't mean the demise of other priority pathogens. And using digital clinical surveillance, they were able to still monitor what was going on with other multi-drug resistant pathogens as well as with COVID. So we know that, IPC is so important for patients, it's important for healthcare professionals, and it's important for the general public. And ensuring that we have our teams able to handle the increasing workload at the time when they needed it the most. I think that was the main message we got back from our customers. And as suppliers to the NHS, it was a really heartwarming thing for us, because we knew that we were making a difference at a time when the NHS really needed us.
It's so important, making a difference. Lucia or Lucia, can I check the pronunciation of your first name before I call you the wrong thing all the way through?
It's fine, I'll answer to anything. It's Lucia.
Lucia, it's very, very pretty name. I mean, Lucia, knowing what you have infection control, infection prevention and control in your title. What have the last 18 months been like for you at Newcastle?
It's been a bit of a roller coaster. Obviously, we received the first. Our centre was the centre that received the first patients in the UK, and that was a challenge in itself. And at that time, it was very, very clear. In Newcastle, we're very good at coming together all the time, but particularly at times of crisis. So we went from an awful lot of unknowns. You know, we could see what was happening elsewhere. We could see what was happening elsewhere in Italy and in Spain, and we had time to prepare in a way and to anticipate what could for some possible scenarios, but nothing, absolutely nothing prepared us for what actually happened and for the last 18 months. And we have gone from that, the unknowns, to a very rapidly evolving landscape with an awful lot of change. One of the challenges has been to keep up to date with all the constant change in guidelines and updates. From anything from infection control precautions to how to manage and treat the patients. So we've gone from that to having to live with it, and knowing that we're going to have to live with it for a long, long time. And what happens outside of hospital and what happens within the hospital are two very different things, and having to marry up all those human behaviors of, you know, what I can do at the weekend, and I can meet my friends at the pub, but in the hospital is a very, very different thing. So the challenge for us has been to bring everyone together in something that we've always said forever. Infection control is everybody's business. We are all infection control practitioners, because you're only as good as what you're doing at that particular moment in time in front of the patient. I think the last 18 months have brought that very much at the forefront of people's minds, and we have in a way benefited from that. You know, we are all this, we are all in this, and we all have to work with this. But I think moving forward, our challenge is going to be to maintain that level of activity and with the precautions that we have to follow. So interesting. If I had to summarize it, I would say it's been a mixture of it's like a roller coaster, very much, you know, terrifying, and it has had some good bits, but it has had some difficult bits as well. Yeah.
Lucia, we've all been on this terrifying roller coaster, whether we work as healthcare professionals or, you know, we're just ordinary members of the public and trying to keep our families and friends safe. And knowing what we know now about COVID and the variants, do you wish you'd done anything differently?
I think overall for us, in our organisation, I would say we've been very lucky and probably not. I wouldn't, you know, there's been days that you wish they had done nothing different. But overall, no, I kind of wish that from a vaccination perspective, and something that was out with our control, knowing what we know now and knowing that vaccination protects everybody, I think it would have been better if we had kept with the initial schedule of vaccination and just keeping those 2 doses a bit closer together in time. But outside of that, obviously each organisation is a whole world. I think every death that has happened as a consequence of COVID, whether it is as a consequence, you know, infections that they have acquired in hospital or not, is every death is a story and is a tragic story. But for us, I think we are lucky that we fared well.
What's COVID taught you about how to engage with the population in infection prevention? Chine, I mean, the public has become very aware of interest in IPC, which is an acronym for perhaps not familiar with. How do you think healthcare leaders continue to communicate with their audience?
I can hear an awful lot of background noise, but I can't really hear.
Yes, let's just have a look. We seem to have got a few sound issues.
Oh, there you go. I can hear you now.
Oh, can you hear me now?
Yes.
Oh, Alice, you can hear me now. Brilliant. I was asking about what COVID's taught you about engaging with the public and, how key has that communication been?
Yeah, so, I mean, I think that at the start it was really interesting because everybody came together, everybody felt like they were in it together, I mean, if you remember that first wave where people were stood on doorsteps clapping the amazing NHS and social care and other key workers. And I think that the motivation at that point was really clear for people. So you're starting with that motivation, and there was a real fear around protecting ourselves, protecting our families, protecting our communities. And that kind of brought us all together for that first phase. And actually that felt amazing at the time, as difficult as it was. But it also meant that we were able to achieve a lot as a society, really, in terms of being able to offer as much protection as we were able to at that point to those people who were most vulnerable. But I think the issue became obvious fairly soon that actually, whilst we were all in it together in many ways, the impact, both in terms of the risk of COVID, from a clinical perspective, but also the impact of the mitigations was felt really differently by different groups and different communities. So for example, children are relatively, thankfully, low risk from COVID, but actually the mitigation of closing down schools was huge. And it's really negatively impacted on all of our kids. And whilst that might be okay for someone like me, I've got access to space at home for my kids, I've got access to good quality IT, all of those things became even more difficult for some of those communities. So the things that we were asking people to do were felt very differently. So, I remember talking to a lady who'd been asked to isolate with her child. Her child had been a close contact of a case. She'd been asked to isolate with her child, but actually because she hadn't been asked to isolate herself, she wasn't able to get any of the income support. If she hadn't gone into work, then she would have ended up potentially losing her job. And, there are lots of the challenges that actually what might sound relatively simple actually became really difficult. So for me, it became very important to understand how it was feeling for our communities and how it was feeling in different places and in different ways. Because I think you can only ask people to do things if you really understand the impact of what you're asking them to do. And so what we did in Gateshead was we started with some of our community voluntary sector partners who've already got trusted relationships with many of the communities that we were trying to reach. And we engaged them so that they could help us listen to understand what was going on and potentially provide us with advice and support as to the mitigations and support we needed to provide. But the other opportunity it gave us was to involve people in the solutions, because I think it's all well and good when it's coming top down. And in those first weeks of crisis, where we were thinking, oh my goodness, it's going to take 2, 3, whatever. We never thought that, but lots of people thought we could have a couple of months and then it would all be okay. Whereas the rest of us kind of knew that it was going to go on for a longer period. So involving people in the solutions, I think, has been really key. And then also the messenger's really important. So actually a message from someone like me may not resonate with many people. And, as much as, whatever professional training I've got to accept that there are actually better people who can communicate with different parts of the community. So we did all sorts of things in terms of engaging people in how to give the messages and the messages that were given. And, so for example, we had an MC person, this is my age now, a rapper who did this amazing rap for teenagers, to actually just sort of like, and then encourage them to engage in a competition around actually some of the things that we need to do. So like I say, loads of creativity, none of it mine. But, it is that bit around understanding the motivation, understanding the impact of what you're asking people to do and making sure you've got the right messenger.
And just briefly, Alice, Vanessa Cooper asked, do you think the community fully understand now?
No, and actually that's probably one of our challenges over the last 12 months is that the guidance has changed at different points. And actually David had referenced something in the earlier presentation around the fact that we had this disagreement around whether mask wearing should happen, and actually, learning from other countries, like David said, was actually, let's just go quickly and not always be worrying about whether we've got a randomized controlled trial to prove it, but just be really clear on the messaging. And we have tried to do that locally. But like I say, it does, because people don't understand the nuances as what you can do that, you can go into a supermarket with somebody who's not in your family, but you can't have a cup of coffee with your mum. And, I think we just needed to keep those messages much more simple and much more straightforward. And, right from the start, the key things are, there's not one silver bullet for this, but there is social distancing, isolation with, if you've got any symptoms, good hand hygiene and good, sort of other surface hygiene, but also making sure that places are well ventilated. Outdoors is better than indoors, but we're expecting people to understand things that we've spent years training for, and actually it isn't straightforward and it isn't simple, but we do need to find a way, which goes back to the messengers and engaging the people in the solutions. So I think we've got loads we can learn from this. I don't think it's been perfect by any stretch of the imagination.
Do you want to add about healthcare leaders and, how you feel that they're able to communicate with confidence to the audience to make sure that, these messages are getting through, loud and clear?
Did you ask the question to me, Helen?
Yeah, I did. I just wondered if you wanted to add to that.
Absolutely. And it's a very important point that Alice is raising around communication. I think from our experience and what we've seen throughout the pandemic, having clear communication is key and was very key to ensuring that the general public were able to comply with what was the interventions that were being put out and with all the things that the government was asking us to do. And for us, we have always advocated for digital clinical surveillance because a lot of confidence in communicating has to do with understanding your data. If you don't understand the data, then you don't have any confidence in communicating and conveying the message to the audience you're trying to convey the message to. So we all know that the key to any effective and confident communication is knowing your subject. And if our leaders are confident in the data that is informing their message, then they're able to communicate with more confidence, and that confidence actually shows through to the public and to the audience that they're communicating with. And if you think about IPC, especially when there's an outbreak, the workforce are often dealing with critical scenarios, and there's a need for speed in obtaining and disseminating the IPC data. And that need for speed, we saw it even more during the pandemic. We saw that we needed speed in getting information, we needed speed in getting the data through. And that would, and the speed is what would help in communicating, effectively. So it still goes to my point about automating clinical surveillance because, those systems enable timely generation and dissemination of data that then allows for a quick response. It allows, leaders like Alice at a public health level to be able to respond quickly, to make those decisions in a timely manner, and also communicate to the public with well-informed data. So what does that then mean? When people like Alice, people like Lucia are able to communicate to, whether it's the healthcare staff in hospitals, whether it's the general public, it then means that, whether it's patients, whether it's the public, whether it's healthcare staff, they get that information. They see the confidence through our leaders when they're communicating. And if you're not very sure about what you're saying, people will actually see it. And so I would say, as we keep driving for automating clinical surveillance, we're saying, automate clinical surveillance. That helps to get the data out quickly. That gives our leaders confidence in the data that they're using to communicate to the audience. That improves the time to intervention, and it ensures that we have those measures in place that will then help to stop onward transmission in scenarios where we have outbreaks. So it's all about confidence in the data, I would say, that really helps with the confidence in communicating.
Lucia, I saw you nodding through quite a bit of Chine's answer there. Was data really key?
I think there was an awful lot of what Alice and Chine said that resonated. I think communication is really important. Data is absolutely fundamental. I really liked David alluded to that about being more open and honest about what our rates are, sharing the healthcare acquired infection rates in different areas, so that we can learn from the best, who is doing well at this and what can we learn from that. I think that Alice is right about in 18 months we've had to communicate messages to the general public that they've never had to deal with. I remember several years ago having to do a patient leaflet where I couldn't I had to use bug instead of bacteria or virus, and now everybody knows what the difference between a bacteria and virus. There has to be there's been an accelerated learning in the general public, and that we must think about and reflect about what is that telling us about where does education about infection begin. And it probably begins in early years and in schools, so that when we have the next of these, because these things happen, pandemics do happen, when we have the next one, we can engage with the public a bit earlier. Chine is right. The data has to be clear and it has to be useful. Data is not necessarily numbers. Is how can you translate the data into information that is useful for people, and is having different solutions for that is absolutely key. So I was nodding a lot because I agreed with everything that the others were saying. Absolutely resonated.
I'm looking across the right-hand side of my screen constantly, not because I'm not listening to what you're saying, but because the inbox is flooding with questions, and I'm also looking at the time, realizing there's only 5 minutes left. So let's just whiz through and see if we can take a few questions. Subramanian says, one of the problems for IPC leads is dealing with clutter in the hospital. Many hospital areas are built without of storage. Some of this equipment are unnecessarily large. Do you think this pandemic would make us rethink these areas? I guess that's Lucia.
100% agree. When you are faced with people tend to compromise in storage spaces because they're not clinical spaces. But I think and all of what we've learned in the last 18 months, we must use moving forward, and things like the design of hospitals and clinical spaces, taking into account things like ventilation and hand washing facilities, but space in general. Where do we put all of these equipment? What are we going to do with this equipment? Where's the flow of equipment and so on? These are things that we absolutely must not lose this opportunity to learn from.
And another question, it's actually for you again, Lucia, if that's okay. Richard says he'd like to ask you, in Newcastle, did the deep clean and cleaning regime change? And if so, did technology help with this? Also, was this monitored and did it return greater results?
We used a lot of what we knew already. So we have got a team whose job it is to do urgent cleans and fast cleans out of hours and within hours. So we do have a team that's dedicated to that. Obviously, we've done quite an awful lot of work in the previous year, so we knew a lot about what works and what doesn't work. There's been a change from what we were doing at the beginning of the pandemic to what we're doing now. But we do monitor all of our cleaning. Technology has helped. We have used things like hydrogen peroxide as well as UV lights. and we use this other monitoring technique just to monitor that we have cleaned it. So yes is the answer. So it has changed, but we have built on what we knew already.
Alice, Lucia says, obviously, we are going to face this again, aren't we? Whether it be with different variants of COVID-19 or potentially another pandemic in the future. I'm just wondering if you can sort of give us the key lessons that you feel you've learned from this, and whether you feel that we're in a much better position, both in the healthcare industry and, us as members of the public, should, God forbid, anything like this, strike again.
Yeah, I mean, my overwhelming reflection of the past year is when things have worked well, it's because we've pulled together as communities, whether that's inside the hospital or outside the hospital. And so actually public health is the art and science of improving health and well-being at a population level through collective action. And I think infectious disease is the perfect example of this as an approach. So for me, the biggest thing that we need to resolve now in the UK is addressing the issue of inequalities. Actually, I do think that we would have dealt with this pandemic in a much more effective way. We would have had fewer deaths, fewer hospitalizations if we lived in a more equal world, because what it's required us to do is to care about everybody around us. So it's no good just thinking about me and my actions and me and my family's actions. It's about me and my actions and how they impact on the rest of the community. And I've talked already about the first few months where everybody really came together, and this felt, really quite powerful. But there is something about actually the things that have meant that people haven't been able to, at a population level, do or take the necessary steps to either protect themselves, their communities, or indeed the broader sort of UK, or actually you could even look globally at this, are the things that, that we need to now address. And, so you've just talked about cluttered hospitals. Well, actually, we've got houses that are overcrowded. We've got population density. All of those things made it incredibly hard for some people, which meant that they were more likely to be exposed, more likely to be vulnerable to the virus because of the impact of, sort of wider determinants of health. And so for me, what I'm stepping back now and saying is we've always been driven by the need to address inequalities, but actually we need to be thinking about how we address inequalities, not only because it's the right thing to do morally, but because it actually has a bigger impact on population health. So that's my overwhelming factor from this, is we need to really get a grips with the fact that we've got growing inequalities in the UK, and we need to really sort of turn that on its head.
Completely agree with what you said there, and I hope that if there can be a tiny silver lining, is that it's perhaps made us a more empathetic society, that we've tried to take care of other people who we realise need a bit of help, whether that be the elderly, whether that be families living close by who haven't got the technology for the online schooling and all that kind of thing. I hope it's made us a kinder society through being together. But Chine, we've got to make sure, haven't we, that there's coordination and synergy between the different healthcare sectors now, to make sure that these IPC do provide tangible benefits, and that everybody learns from this, from the wealth of experience that we've heard in the space of about an hour this morning. That's, how do we do that?
That's a very important question you asked, Helen, and thank you for asking that. I think if we go back to what has happened, we'll see that the pandemic definitely exposed, certain weaknesses in our infectious disease surveillance and our response capabilities in almost all countries, and I would go ahead to name, some of the various aspects that we didn't particularly meet the standard that we would have liked to see. But if we refer back to Public Health England, they published a strategy, their 5-year strategy, back in September 2019. This was before the pandemic, and one of the things they talked about was linking and integrating data in order to improve surveillance. So Public Health England, and Alice, you will be very familiar with this, so we're very well aware that, technology is key in terms of improving surveillance when it comes to managing infectious disease threats. And certainly, that is one of the ways that we can ensure that there's coordination and synergy between the different healthcare sectors, because what is needed is data integration that cuts across the whole health economy, and that also enables IPC data to be utilized at a population health level. So we're talking about countrywide regional or local infectious disease surveillance and response activities. There are organizations here in the NHS that saw the problem ahead of the pandemic. They saw the importance of investing in digital clinical surveillance. And during a crucial point in their work, that investment paid off. It was of immense value to them. I've talked about some of the feedback we got from our customers. But what we have seen now is an additional engagement with us, both at a trust level and at a population health level. So we're talking with ministries of health at a country level who have recognized that they need IPC solutions to tackle infectious diseases threats at a country level. And, pulling information both from hospitals and the community. So the forward-thinking trust in the UK, those of them who have already invested in digital clinical surveillance even before the pandemic, they're going ahead to start thinking about, how do they integrate their data with the community, with community trust, with GP surgeries, and all of that. So one of the ways I would say that we can indeed, like I've said already, indeed ensure that there's coordination and synergy is linking and integrating the data across the whole health economy, but not just the whole health economy. We need to include public health as well.
For Lucia and Alice, a final word. Lucia, instead of asking, I think I'm going to take a question from Fatty, who says the single most important issue when considering preparedness for the next pandemic is hospital estates. We must start now making sure that hospitals are built with ventilation and isolation and are given correct consideration. Otherwise, we'll have to use blunt tools like lockdown. Again, we will be talking about hospital estates later, but I just thought I'd take your view on that.
I absolutely agree, and that has to come. There needs to be an awful lot of the NHS estates is very old, and investment, ongoing capital investment has not been there for many years. So we are behind, and we also have to build forward. So that I couldn't agree more. There needs to be significant investment and the realization that that this is just not going to happen. Ventilation is not just about opening a window. So there has to be a significant investment from the central government to make sure that we are prepared and that our patients receive the best care in the best possible environment.
Alice, no pressure, but you are getting the final word. If you had one key message for policymakers of the future, what would that message be?
Well, it would be to start with addressing inequalities and do this in a really robust way. And actually, we've got an amazing NHS, and we've seen that over the last 18 months, but only 10 to 20% of health outcomes are driven by healthcare. We really need to look at those wider societal issues that are impacting on people's health and well-being, that have enabled them to engage with the COVID prevention measures over the last 12 months. So I've already said housing, the environment, some of those health behaviours that have meant that people are more likely to have poorer outcomes as a result of COVID. I think it gives us that great opportunity to come together in a more unified way and to actually recognise that there's no point being, only caring about yourself and your family. We actually have to care about everybody around us. And I think that would put us in a much better position when we come to face this kind of thing into the future. So a bit high level, I get, but, I think inequalities for me just runs all the way through this.
To talk to you, ladies. Thank you for being our first panelists of the day. You've been absolutely brilliant and raised some really interesting points that will be useful throughout our day and other debates. So thank you very much to Lucia, Alice and Chine